do want to talk about is that if you've been in the world of autism for any length of time, you know that there are all sorts of treatments out there for kids with autism. And you know, too, that as many treatments as there are also just about as many opinions about which of those treatments are best and how they match up to the needs of particular kids. And yet the reality is that we actually know very little about how to match an intervention to a particular child. And what we're going to talk about today is how we start to think about that and how that's kind of evolved over time in originally our separate work and then the things that we've started to do together. So what do we know? Well, one thing we're pretty sure about is that early intervention is important. So beginning in the toddler or preschool years, or as soon as we can after the diagnosis, is important for giving kids with autism the best chance to pick up communication and social skills and other skills that will help them be successful as they go through their lives. And we know that in general, across a variety of early intervention approaches, or even if we don't specifically measure what kind of early intervention, a lot of kids really do improve a lot during these early years. But we also know that autism is a very heterogeneous population. As the saying goes, if you've met one person with autism, you've met one person with autism. And as it relates to early intervention, there's a significant group, somewhere around 30%, that really struggle, particularly in developing communication skills. And so by the time they hit school age, there's a group of about 30% who are still what we would call minimally verbal. That is to say, they have few or no communicative words that they regularly use to and initiate in their interactions with other people. So thinking a little bit further about early intervention, what do we know about quality early intervention? Well, there's no standard of care for autism the way there is for other things. So, for example, if you have strep throat, you get an antibiotic. If you have a cavity, you get your teeth filled. There's nothing equivalent to that in autism. There are all these treatments and all these opinions. But the most commonly recommended treatment is applied behavior analysis, or treatments based on applied behavior analysis. And actually, this area, Sacramento, was the very first place in the world where the community actually came together to try to move these interventions that were developed in university settings out into the community. And that goes back actually to a family organization, Families for Early Autism Treatment, that started in 1993, and some providers and policymakers and people in regional centers getting together and trying to figure out how to get these services available. And I was still at UCLA at the time. We had a lot of people, coming up this way and trying to help things get going. But really, this was the time when the community came together. This really all goes back now a quarter century to this group of families and providers and policymakers who actually managed to get together and get something done. And that was an accomplishment. And the reason why there was such a big movement at the time was that the ABA interventions were really the first ones that were tested in any sort of systematic way and looked promising for improving outcomes for kids. And so people came together and said, we really got to get these out to families. And ABA is really an umbrella term that includes all sorts of things. But there's particular kinds of ABA programs that are most common in early intervention for autism. And those are programs that involve a lot of highly structured teaching, one-to-one teaching, and use a format called discrete trial training, which I'll show you in a second. But the general idea is that these are kids who have had trouble learning in the ordinary kind of interactions that kids have with their parents. And so what we're going to do is we're going to sit them down and kind of lay it all out for them and teach them step by step what they need to learn.
Match! Hooray, that's matching! It's toys! 2 more. Match.
Much.
You're so awesome. 1 more.
Match.
Match. Wow! Hooray! High five!
So as you may have gathered, this is matching, as she said. All right. So the idea here is that we wanted the child to be attending to the instructional materials and telling the difference between what's out there, and that kind of skill is a good stepping stone to being able to learn in a lot of other teaching situations. So that's one kind of thing that we teach. And we can go to the next video, which is really understanding language spoken by other people.
4 daisies. Okay.
This.
Those are pretty. Cat dog. Nice job. You got it. Push block. Good. That's pushing the block. Let's do 2 more. Push block. Way to go. Okay, 1 more for book. Pat dog. Oh, so nice, Kaylin. Way to go.
And so here again, we're very much kind of breaking this down to one little skill at a time that we're going to teach. So one was matching to help with kind of attending skills for learning. Now we're directly teaching comprehension of language. And then the last video, it's Connie's favorite because she does this very differently, is teaching play skills.
Answer phone.
Hello.
You got it. Do this. Pretend to be T-Rex.
Whoa.
Yeah, bud. You got it. Pretend book is piano. You are so smart. 1 more time. Pretend book is piano. Wow, nice working.
So again, even with something like play, from a discrete trial standpoint, what we're trying to do is break it down into like this, these are different play skills, and we're going to show them how to do it. Again, these are the very first programs to be tested in any systematic way, and so they've been around now for a while. So what do we know about them? Well, we do have pretty good evidence across studies that we can accelerate kids' development of cognitive skills. So you'll notice, like with matching, we're really teaching, things that might show up on an IQ test or an academic kind of pre-academic skills. And applying the same sort of things, we also, in most studies, make pretty good progress on teaching self-help skills like dressing yourself and using the toilet and grooming and stuff like that. So those are important skills. But what you didn't see so much of in the video was work on some other things that are important in autism, and in particular the back and forth social communication. So the core deficit in autism is not necessarily following instructions or anything like that. It's really being able to have a back and forth interaction rather than this more teacher-led interaction that you saw in discrete trial training. And when you look at outcomes in those areas, it's not so clear that discrete trial programs actually help. And in these programs, too, you get the same kind of heterogeneity that you see in lots of things when you look at kids with autism. So there's a group of kids who do really, really well, roughly 30%. There's a group that really has a tough time at the other end, somewhere around 20%. And a lot of those kids are what we would call minimally verbal. And then there's a group of kids in between, which is a very mixed group of kids. Some of those kids, too, would be considered minimally verbal. And so, again, you see these kind of mixed outcomes. As recently as 10 years ago, Sally Rogers, who's one of the speakers today and from the Mind, wrote a very nice review that's been cited something like 1,000 times now, which is the academic equivalent of going viral. So it's like, and it's a very nice review. And she said basically, the only things that are really well established are these DTT-based programs. And then there's stuff like what Aubin studies that show some promise, and there's some other things that show some promise, but that's kind of about it. But as it turns out, in the last 10 or 12 years, there's been a huge change. And there's been a whole lot of research, and much as I hate to say it, as someone who was involved in the early discrete trial research, the new research is better. So they have more kids in the studies, they do a better job of equating the treatments they're testing against the other thing they're comparing them to. They do a better job of measuring outcome. There's lots of things that are better about those studies. That doesn't mean necessarily that the treatments are better, so we'll come back to that point, but the studies are better. And the most study has gone around things, a set of interventions that are called naturalistic developmental behavioral interventions. And these interventions really include ABA, so they're not opposed to ABA, but they incorporate other things too, and they tend to look a lot different from what I just showed you. And importantly for autism, they really go right after the social communication in the context of the kind of situations where most kids learn back and forth social interaction. And so people have thought, particularly for little kids, the early intervention kids, this may be what you ought to be doing instead of the more directive treatment. So Connie was kind enough to let me show an example of that, so I will show an example. And there are a number of different NDBI interventions, but an important one is the one that Connie and her group has been working on called JASPER, which is short for joint attention, symbolic play, engagement, and regulation.
I see the tiles.
Where's the treasure?
Let's find the treasure.
There she is.
Oh, there's the treasure.
Oh!
Oh,
I got the money.
oh, I have money too.
I got corner.
You have coins. Oh, I have coins too.
Yep, you.
Oh, I have so much treasure.
Let's find it.
Let's find it.
Tiles in the birthday.
I see a birthday.
Perfect. This is everything's smooth speaking.
Oh.
Shady.
Arg, say the pirates.
Yes, yes, you.
Arg, say the pirates.
Ready to birthday. Yes, that's. Let's run this up. Mash. And there's on tiles.
I see lots of tiles.
Ah!
Oh, the pirates crashed it. Woo!
Whoa! Stroke!
Let's start.
Start!
He can read.
You can read?
He just said start.
Whoa.
I see the treasure.
Look at Chase and look it!
What is it?
The tile's trashy.
Oh, the tiles are trashed?
Crashing.
Oh, crashing.
Ooh, look at the treasure.
Necklace.
I have a necklace.
Oh. Oh.
Yours is so pretty.
So again, that looks very different, right? So, and it looks more like how in the ordinary course of events, young kids with or without autism might be learning how to interact with other people. So now we have at least two very different types of interventions. But what we don't know is how we might, and they both have some empirical support, but we don't know how to choose one for a particular child or even how they stack up head to head. And we don't even know like how we might think about characteristics of the child that might lead us to favor one treatment over the other. So with that, I'll turn it over to Connie to talk about how we start to think about that.
Yeah, so all of those kids are interesting because they were all minimally verbal, which is a subgroup that Tris and I have been really interested in and working on for the last several years. And it really grew out of some early data that I had done at UCLA as well, where we were interested in how you would choose the intervention based on where a child sort of begins, what their characteristics are. And so if they have limited language, should you choose DTT? Or should you choose something like Jasper in order to promote that language? And so in a very early study, I had looked at kids who got sort of a focus on nonverbal communication gestures like joint attention, which theoretically predict to language, and we actually have evidence that they predict to language in other groups of kids. Or play skills. If we improve play skills, would that predict to language? And then if kids just got the applied behavior analysis, kind of a DTT approach in the community, would they make progress in language? And so this first graph on the left-hand side is 3 groups of kids all getting about 30 hours of applied behavior analysis. And one of the groups also got joint attention, one of the groups got play, and the other group just got ABA. And what we found was that kids who got content related to joint attention and play skills, sort of more developmental, actually improved more in language than kids who just got an ABA program. And this was a long time ago. This was in late 90s. So kids in ABA weren't getting much focus on joint attention or nonverbal gestures at that time. And so that was really interesting, but then when we break it down to what kind of language you have to start with, so kids who had fewer than 5 words in their repertoire, but they were 3 or 4 years of age, those kids actually did better if they got content on joint attention. So that's the graph on the right. So those kids made in about a year's time, they made about 13 months gain in language compared to kids who were only getting ABA, which made about 3 months gain. So again, this idea that how you present is going to matter for what intervention we fit to, you as the child. What we don't know is exactly how to select that intervention for a particular child, or if you're responding slowly in the given intervention, what do we do and when do we do it, right? So we could say, it seems like you should have DTT. That's what you can get in the community. But if you respond slowly, should we change something? Should we increase dose? Should we change to a different intervention? We don't have guidelines for that. So in the first study that Tris and I did, I think it was the first one we did together, right? We were interested in whether DTT or Jasper would work for kids who were kind of were what we would consider limited language preschoolers. So these are not your 2-year-old who's already talking. It's not your 3-year-old who's, progressing rapidly in early intervention. These were kids that we wanted to have already been in early intervention, but were developing slowly. So they had fewer than 30 words to begin with. And our goal was to try to increase spoken language outcomes in these kiddos, and we compared DTT to Jasper. And these were kids that were getting about an hour of these interventions in the schools in 3 different locations. So in Rochester, in Baltimore, and in LA. All right, so fewer than 30 words, 3 to 4 years of age, already getting services, and they had to at least have sort of cognitive skills around 12 months. But they're pretty delayed. So if you're 3 or 4 and you're developmentally like a 12-month-old, you're pretty delayed. And we were just comparing these 2 treatments. So it was a fairly large trial. It was 164 kids altogether. And again, you've seen the DTT and the Jasper examples. So we randomized kids to get one of these 2 interventions, and after this was a 6-month treatment, but at 4 months, we started moving out of the school and into the home. So we were trying to generalize those skills that we were teaching in school to home. And then we had a 6-month follow-up. So what did we find? Well, we would have predicted from my early work that for these limited language kids, that if you got Jasper, you were going to do better in expressive language. If you got DTT, you might do better in some other areas of development, but not language. And our measures that we examined for our outcomes were the Mullen, which is like a cognitive test that looks at cognitive skills, expressive and receptive language. And then we also did an assessment looking at their joint attention or their nonverbal social communication gestures. And this is something that Peter Mundy here at the Mind has pioneered and been working on for many, many years. And Peter and I go back a few years too. We were postdocs together. Well, what did we find? Oh, well, there's no difference. Which is typical. When I do studies, I usually hypothesize something and something else comes out. So interestingly, though, for both receptive and expressive language, kids made gains, right? Now, we didn't do just a group that didn't get anything. Everybody was getting something, because we're kind of over that, because most kids now are getting some kind of services. And the question really is in this study was, which one would fit better for these kids who had limited language? Both of them were great in terms of kids were making about 6 months gain in 6 months, and they continued to develop at follow-up. But there were some differences in terms of where you began. So if you were a child who came in and you could initiate some joint attention, so in other words, you could point out something to your parent to share attention, or you could show a toy, or you shared affect and attention. If you had some of those skills, many of our kids had none of those skills, but if you had some of those skills, you did better if you got the Jasper intervention. So we could optimize that. Let's see. And also, here is if you had higher nonverbal IQ scores, you had higher spoken language, expressive language at the end of treatment if you got Jasper. So bottom line, if you had a little bit of skill, you did better in Jasper, which is interesting. Because based on all of the data that we had up to that point, and from Tris's randomized trial of DTT, you would have surmised that kids who had more skill, less autism symptoms, would do better. And that's not what we found here. So, and it kind of goes, I think, with some of our clinical impressions that if you have really limited language and you're very, very delayed, building that contingency may be really important for changing development. But we still don't know from this trial then exactly how to combine these interventions or think about sequencing them. So I've already said this, that what can we expect in these kinds of interventions? Well, we kept them up in terms of gaining a month for a month of intervention, so that's pretty good. But there were some differences in how you began. So what we know is that a single intervention isn't going to work for every kid. And it's because of all of the heterogeneity that we have in kids with autism, what works for one kid may not work for another kid, or what works now for one child may not work later. So we need to be smarter about how we go about applying interventions. And so we're researchers, and so we're thinking about those methodologies that we need to apply to really test whether or not a sequencing of treatment or a combination of treatments will actually work better than something else. So we've been involved now in a study or two on using adaptive intervention designs. And what these do is to really systematize clinical practice. So a good clinician works with a child, and based on that child's response, they tailor or they adapt or they change the intervention. And they don't worry about the protocol because they're going off of their clinical experience or their training. But what an adaptive intervention design does is it applies very specific decision rules for whether, how, when, and which measures you use to alter something, whether that's the dose or the type or the delivery of treatment. And so you think about this at various points of time. These designs were really started more in cancer treatments or substance use kinds of treatments. The research part of that adaptive design is called a sequential multiple assignment randomized trial. As you know, most of the research that you do on interventions, to be really systematic and rigorous, we need to randomize children to one treatment or another, or one condition or another. So this one does these randomizations more than once. This kind of a study then has a sequence of stages, and at the end of each stage that you've decided on the time, then you're going to evaluate something. And you're going to decide, are you a slow responder or are you a fast responder? If you're a fast responder, you might just stay on the same course of treatment. But if you're a slow responder, we want to do something different, because our goal is to optimize your outcome. This is really a way of personalizing interventions, so that we know that for you as an individual, we're optimizing your intervention. This is definitely what you want if you're in a cancer treatment, right? But it's also what you want if you're, have a developmental delay. You want to know what's going to optimize your outcome. So the first SMART design in autism was completed a few years ago, and we were really focused on these minimally verbal kiddos. So we've talked about preschoolers that were limited language, right? And so we also know, as Tris said, about 30% of kids start kindergarten and they're considered minimally verbal. So that's not a good place to be. You want to make sure that they're going to be beginning to talk so that they can access curriculum and schooling and other environments more. So we did a study where we looked at minimally verbal kiddos that were between the ages of 5 and 8. They'd already received 2 years of early intervention, so they were not treatment naive. Most of them had been exposed to some ABA. And we decided that we wanted to give them something that they probably hadn't had before, and that would be Jasper, because it's not really out in the community that much. So we gave them Jasper plus a language intervention that's really more like what the kind of work that Aubin does. It's more like PRT, but it's called EMT, Enhanced Milieu Training. So it's really prompting for spoken language. And this was a 3-site study. It was Baltimore, Nashville, and LA. The question that we asked in this study was whether a speech-generating device was going to promote more spoken words, spoken language. And it's pretty controversial. I think it still is, but it definitely was at this time, where you had people recommending it or not recommending it. Some people believing that it was going to inhibit their ability to talk if you had them rely on something that spoke for them. And so in this design, we gave them this Jasper EMT intervention with or without an augmentative speech-generating device. We started off with very expensive devices, and about halfway through the trial, iPads with Proloquo to Go software became very available and much cheaper, so we used that system. So after 3 months, we did a lot of measures on kids, and we decided if they were slow responders in terms of gaining spoken language, or if they were slow or fast responders. If they were fast responders, they stayed the course. If they were slow responders and they didn't have the augmentative device, we re-randomized them to either get the device or to get more sessions. So instead of 2 sessions a week, they were getting 3 sessions a week. If they had the device, we didn't take it away from them. We just increased dose. So it was unbalanced design, which is fine. Well, what we found surprised, I think, a lot of people, in that if they got the device, whether or not they needed that device, whether or not you as an SLP would have given the child that device or thought that was indicated, those kids made huge gains in spoken language. Our outcome was socially communicative utterances, so your ability to communicate in a connected way to another person. And it was done by language transcripts that were done by people outside of the research group. So the top curved line, the first point is the first 3 months of treatment. The second 3 months, we back the parent into the intervention. And so it continues to go, and then the last curve that goes down is where they leave it's follow-up. So some of the kids didn't leave with the device. But I think you should note that the bottom line are the Jasper EMT kids without the device. They're making slow and steady gains. It's not that they're not gaining, but what's happening is it's accelerated progress with the augmentative device within the context of the behavioral intervention. So it's not just giving a kid a device. That's not going to work. It's within the context of the behavioral intervention. We also found the top line, again, is the Jasper with the device. We have more novel words and more commenting language or joint attention language in those kids as well. This is a minimally verbal 5.5-year-old who had absolutely no words and no sounds. And what he needed was access to communication.
Want boat or blocks? Boat on.
Boat.
Green. Sorry.
Colors.
No green.
Colors. Blue.
Oh, you want a blue
Blue.
back.
Boats. Drive.
Drive
boat.
boats.
So he's just making approximations of words, but he did leave, that was halfway through the treatment. He did leave treatment with about 300 approximated words, left with an iPad. It uses language now. So he's just a kid who didn't speak. Very smart. He could program he had a Dynavox, could program that thing after 5 sessions, could read. Smart little guy. But that's how his voice sounds when you don't use a voice for 5.5 years. All right, so a goal in Jasper is really that they can initiate communication, and you can see that he has his ideas and he's initiating. So we now use this idea with younger kids, and so it kind of feeds through all of the work that we do. We're going to give access to communication to any child who we think needs an iPad to help. And so here's an example of a preverbal boy, and I say preverbal because he's 3 years old. He has absolutely no sounds, no words, and he's had a year of discrete trial training, ABA. But he doesn't know how to play, and so in the first video, you'll see the very first session of us just trying to play with him.
On bus. On the bus. On the bus.
So how do we know he had DTT? He completed that task, and he was not going to do it over again. All right. So what we knew about, for that particular kid, that wasn't first of all, we needed to change some things about his intervention. We needed toys that didn't have completion, but were at the same play level. And so in the one right below this video, this is day 2 with the therapist. She's brought in an iPad with icons that match the toys and different kind of toy.
People. People. On.
People on ramp.
People. On.
So he's initiating 2 buttons together, day 2. Just to say that he's now 5 and going to inclusion full-time, has his iPad, can talk, but is not a frequent communicator. So still has his iPad, but can talk in sentences and phrase speech. So that changed his life, right? It's the context of, combining different kinds of interventions. So what we learned was that speech-generating tablets can really help minimally verbal kids or preverbal kids speak when it's combined with an effective behavioral intervention. But there's a lot of variability in kids who are minimally verbal and also in their response to intervention. And so we have now just completed another treatment that you're going to end up with. So this is, again, with the older 5 to 8-year-olds.
So that study largely focused on adding an AAC device, and that's been one hot topic area in autism interventions. When do you do that? Do you do that? And so that's certainly an important issue. But if you step back for a minute, there are really all kinds of decisions that are that you have to make all the time and are often controversial and that we don't really have a lot of guidance about. And so what we wanted to do in the next study was just look more broadly at some of these. And I'll mention just more generally what some of these might be. So first of all, there's the issue of treatment options. So there's DTT and Jasper, but within that there's also lots of permutations, as we talked about. There's another issue is, how do you even know when it's time to think about doing something else? Like, when do you make a decision? And once you think about that, then the next question is, how do you make a decision? Like, what is the actual measure or variable or decision-making process that you use at that time? And then, what are the rules? Like, what leads you to make a particular decision? What are the options? What determines what path you go on? So there are really all sorts of questions once you start thinking about this. And just to spell out some of those a little bit more, again, not going to go through this in great detail, but if you think about treatment options, again, it's not only the kind of treatment, but a big issue is how much of the treatment, the dose. Like, do we, in ABA, we often think, well, we probably ought to step it up, but we actually don't have a lot of data on whether that's the right thing to do always, or even ever. AAC has been a big issue. I think Connie's study went a long way to addressing that. Do we add other things like parent training? Early intervention program often goes 2 or 3 years. And for the DTT-based ABA programs, that is the recommendation, 2 to 3 years. But we'd want to know sooner than that, whether we're on the right path or not. So how soon can we do that? Well, that first study that Connie just showed, we were able to make a decision in around 24 weeks about whether the child was really doing well or maybe could use some adjustment in the interventions. So in this next study, we went with 24 sessions, that is, as an endpoint. And that was actually 6 weeks, so we had 4 sessions a week for 6 weeks, getting us to 24 sessions. And we still weren't sure what treatment to start with, so we randomized again to starting with discrete trials or Jasper, and we worked on trying to figure out a way to measure whether we were on the right path or not. Now, in practice, In ABA, for example, people use often curriculum-based assessments like VB map, the verbal behavior milestones and achievement. That. Well, that's a pretty long measure. And so usually in an ABA program, it's done maybe 6 months or in conjunction with the IEP, maybe more often than that. But it's something you can't really do a lot because it takes a while. And so we wanted to come up with something, we're aiming to make a decision in 6 weeks. And we're aiming to get them started right away with something else. So we wanted something quick. Basically what we ended up with was coming up with a rating, and I'm not going to dwell on the details, and unless you have an eagle-eye vision, you probably can't read that. But basically what we did was really kind of standardize what the clinicians were looking for. And really what they were looking for was improvement in spontaneous social communication. And if they're seeing that with whatever they started with, then the thought was they should keep on doing that. If they weren't seeing that, or if they were only occasionally seeing that, then that was a sign that we should start thinking about something else. Then, in thinking about, well, what do we actually do? Again, I'm going to just give you a very quick overview of the idea rather than going into any particular details. But the general point here, I think, we've been stressing. So these are kids who've already had early intervention services. They're still minimally verbal. Now they've been in our study for 6 weeks, and they haven't responded to the first line intervention as much as they hoped. So now, whatever we come up with, we're going to have to be pretty creative and individualized in figuring out what we want to do with these kids. And we want to be able to take advantage in the way a clinician would or a family would of what we've learned from the child. Like, why is it that they don't seem to be progressing as well as we had hoped? And to somehow factor that into all the different treatment options that we have and come up with an individualized treatment. So again, I'm just going to present you with the basic idea. What people have started to do in other areas of kind of behavioral health services or mental health services is to develop what's called dashboards. And it's just like a dashboard in your car or something where you have sort of critical things about how the car is doing, like how fast you're going, how much fuel you have left, how fast the engine is revving, all of those kind of things, right? So getting just some key things for you to look at. And then when you're using these things in practice, you want to go a step further and use that information to pick out components of interventions that you're going to use. And so you end up with something that looks like this. And this is actually from a more general mental health intervention that didn't really involve kids with autism. But this was a group, Bruce Chirpita is now at UCLA, and really kind of pioneered this approach of really kind of picking and choosing from different interventions. So, for example, if we think about just DTT and Jasper and AAC, there's really lots of things we can do. So in some studies, for example, Connie has started sessions with discrete trials to kind of prime skills and then go into a play session that's more like what she showed you for a Jasper session. We could, on the other hand, embed, just go right into a Jasper session and embed discrete trials within the session. Or we could do mostly discrete trials and a little bit of Jasper. Or we could mix in AAC and any of that. So there's really lots of pieces that we could do. And it could depend really on what our concern might be. So for some kids it might be like the child that Connie showed, that they've had enough discrete trials and they'll grudgingly do what you ask them to do, but they're not loving it. She shakes her head, nods her head. It does happen. So in that case, maybe maybe we ought to be doing mostly Jasper. On the other hand, there are also kids, if you set up a situation in Jasper, it's hard to engage them in the play materials, and they may just run around the play area. And they may actually need more discrete trials to kind of get them front and center and ready to learn in a more free-form situation. Connie's not so sure about that. But anyway, I'm just giving you examples of all these permutations, just taking 2 or 3 treatment elements. There's really lots of different things you could do. And so we basically set up a dashboard where we identified what the needs are for the child and what components and how much of the different treatments that we wanted to use. So again, we had a dashboard for mapping things out. And so this way we have a replicable decision-making process, and we can retrace our steps. How did we decide what we were going to do, and what did we actually end up doing? And so we put that all together into a study, again, focusing on these minimally verbal kids, about the same age as in the study that Connie just described. And by this time, there was a standard definition of minimally verbal, which is a little different from before, which was 20 words. But really, we see very few kids in the 20 to 30 word range. So this is pretty much the same population type of kids that we've been seeing. And it was 4 sites, UCLA and Rochester, along with Kathy Lord's group at Weill Cornell and Ann Kaiser's group at Vanderbilt. And having learned from that previous study, all the kids had access to an AAC in the study. In Jasper, it was taught in a more consistent with an NDBI approach. In DTT, it was more consistent with an ABA approach, and particularly not exactly PECS, but kind of how PECS generally looks. And here's the design. So I think the general point is what we want to get across here, which is that we've now come up with a design that actually mirrors the ongoing decision-making that happens in practice, where you make an initial decision about what you're going to do, and so we randomized kids. We still weren't sure whether to start with DTT or Jasper, so we randomized there. After 6 weeks, we made an evaluation. Are they progressing as well as we hoped or not? If they were, we kept going with what we started with, and we considered adding in parent training. So they were randomized to just do exactly what they were doing before, or to add in parent training. If they weren't doing so well, and most of them had learned something, it was just whether it was enough that we felt like they were really on a path to acquiring a meaningful amount of communication. Then they were randomly assigned to keep going, because we still weren't sure, like maybe if you just went longer than 24 sessions, that they would start to come around, and that would work just as well as trying to do something more complicated. So that was one possibility. Or they could be randomized to this combination approach, which we described as a rescue approach, where we really used that dashboard to individualize treatments for them. And we did that for another 10 weeks. And then we assessed how they were doing at the end of that, came back 2.5 months after that, and 4 months after that to see. And we're still trying to figure out what the data are telling us, so we don't know the results yet. So we've made things sufficiently complicated that it's not like we can immediately know the answer. But I think the general point is, though, we now have a methodology where we can start to look at these things. So this general approach, this methodology of SMARTS, really afford us a way to model what it is that providers and families are already thinking about. They are, though, probably going to require us to expand our horizons, because what we're doing actually is going beyond what people would typically do in an ABA program. So Connie mentioned that Jasper's not out there so much in the community, but as we're seeing it holds up, and in some ways was more effective than discrete trial training. So what that means is that practitioners are going to have to start thinking about, like, how can I bring these things into my practice? More just beyond all of that, they get us closer to the idea of doing personalized interventions. So we started off by saying these kids are very, very different from one another. They're very much their own individuals. And how can we reflect that in treatment, and how can we do that in an evidence-based way? We've made a start, and we are continuing to use this kind of approach to really work toward this idea of personalized interventions.
So when you say DTT, do you mean just straight the kid is not leaving the tabletop?
No, that's a good question. So in the study, the DTT conditions were all DTT sessions. We didn't, depending on the study, the sessions were somewhere between 40 minutes and an hour long. We didn't keep the kids at the table without a break the whole time. So generally the sessions would be pretty typical lengths. So depending on the child's attention span and how they were doing in the session, the session would go a couple minutes, and then they'd get a break, and then they'd come back.
I guess what I'm saying is that it was straight discrete trial.
But we didn't do anything else, yeah.
Yeah, nothing else. It's not like just an ABA program, because ABA programs right now are all not just drill and kill, like sitting at the tabletop.
Right.
A lot of them look like Jasper-like programs.
Yes.
Okay.
So a lot of programs have moved more in that direction. So like verbal behavior programs often incorporate more naturalistic child-led interventions.
Yeah, PRT and stuff like that.
One of the things we were trying to do, besides taking two approaches that already had a track record in research, was really take things that look pretty different. So the issue, Sally's done some great work that she'll talk about later, where she's actually compared full programs with the full range of techniques in both of those programs. And it's very important to do that work, because that reflects a lot of what's going on in the community. But it's also kind of messy, because there's some overlap then in the treatments, and it's hard to know what of all those things is actually driving the outcome. So here what we really wanted to do was have a clear contrast, discrete trials and Jasper.
Okay. And when it said minimally verbal and under 20 words, was there, for example, did they have to have 5 words and then under 20 words? Or was it just under 20 words?
Yeah, so there was no minimum.
And also, even when, for example, like what I noticed is when the kids come out of the program, I'm sorry, can I still speak? Or
yeah, sure.
Okay, thanks. So when the kids come out of the program, it was meant for them to be, they were minimally verbal, and some of them were still minimally verbal. So it wasn't, you guys still want the kids to be verbal, that's the outcome, versus just to be able to communicate.
So I think we were certainly looking at vocal speech, but we were also providing them with the AAC devices. So we're definitely interested in their ability to communicate in some means that allow them to express themselves.
Yeah,
Go ahead.
so I think if you're talking about that first study, the 5 to 8-year-old study with the augmentative device, we have 6 or 8 studies published off of those data, and the kids they improved in communication gestures, in joint attention, in using, pointing, and showing, and in engagement and in play. So they're improving in a lot of different areas, and yes, spoken language, because that's often the goal of families, but some of the kids were just communicating more, including using the device. The device was used for about 10% of their total communicative utterances.
Yeah, for example, my son, he can speak, but functionally he's considered nonverbal because he's not understood by non-familiar listeners. Yeah. So his, mode of communication is the device.
Yeah, and it cleans it up for some kids, right? So there's a lot of really interesting aspects about the device and why it might help kids, which we actually don't know the answer to, but there are a bunch of different hypotheses.
Okay, thank you.
Mm-hmm.
You were referring to the augmentative communication device, and we've been using an iPad with our nonverbal 3-year-old. But what's confusing to me is that the program you guys were showing is totally different than the apps we have. I think there's probably about 50 apps at this point.
Yeah.
And I mean, I feel like it's almost new to the therapists we're also working with. And so, is there some way that we can, better fish out, like, or determine what is the proper program to be using, and what would you recommend? And then, are there trainings associated with it for people who are working with the child, the parent, or the therapist, so we can kind of all coordinate a little better?
Yeah, so there are a lot of, so bottom line, it's not the app. It's not the app. So you could we use Proloquo to go just because it was available and fairly easy, but there are other ones that are free that you can download, like Sounding Board. And I don't know if there are SLPs in the room, they know a ton of these different apps. So it's not so much about which app you use, but how you use it. And it's within the context of the behavioral intervention. That's critical. So it's not giving a child an app and expecting them to use it, or even giving it to them and prompting them on how to use it. One of the things about Jasper, and even DTT to some example, is you're setting, well, it's different, but you're setting a context for communication. You're giving them a topic. So for us, around play and toys is the topic of little kids. And so all you're doing is creating a topic. You can do that in DTT as well by having, different kinds of board games or other things where you bring in that iPad. It's not how we used it in that study, but it is how we're using it more in the second study.
Yeah.
So I think what's critical is that, and the other thing is that we're model on it. We're not prompting the kid to use it. We might prompt if we get no response at all. But typically, like the little boy I showed you, the 3-year-old, we modeled and he produced 2-word utterances. So he already had a lot of skill within him, and all we're providing is that access.
Just a more general comment. I think there have been a couple of concerns in general about using AAC. One is that any sort of AAC might interfere with the acquisition of vocal speech. And the second one is using any sort of electronics might, the kid might focus on the electronics device and not use it to communicate. So we certainly have kids get into the iPads and do all kinds of stuff with them. But as far as the communication goes, we have not found a problem. It helps their communication rather than interfering with it.
You have to lock out YouTube. You can lock out a lot of things, and then it's just used for communication.
Yeah, in there.
I'm a family doctor, and I have a practice that's about 80% Spanish speaking. Mm-hmm. And when you talk about early intervention, these parents that are asking questions are very empowered parents. Mm-hmm. But so you work with them for an hour a day, and then there's 23 other hours. Mm-hmm. And the kids are having meltdowns and just generally creating chaos in the family. And when are we going to develop an early intervention for parents?
So our Autism Intervention Research Network for Behavioral Health has done that. So we're all about empowering parents and teaching them about the kinds of the ones that we're doing right now are helping parents figure out what it is they need to advocate for and what's available. Sometimes parents don't know what's available. We've also, as part of this grant, gone into homes and worked directly with so our focus is on low-resourced families. In LA, for me, that's primarily Latino families, and many of them are Spanish-speaking. We've done advocacy programs for parents in Spanish. I have native Spanish speakers that go out into homes. So we're all about that, but there's not enough. I'm with you. There's not enough out there. We can't implement and get things out into the community fast enough. But there's two things happening here, right? Some of the things we need to test to know what to put out in the community, what's useful. I think our AirB network has worked pretty hard to partner with families and with community health agencies to get their input into what we should be doing. Because we're researchers, we know some things, but we need to know a lot more about what the community needs and what would be helpful. So we're trying.
How do I explain to them what to make of this kid? I mean, the level of awareness isn't there. So you can teach them advocacy, but first you have to help them understand that this kid's not manipulative, that he's not bad, that he's just, okay.
Yeah, I'm with you. I mean, we have access to early intervention in California, so we need to do a lot better at training providers and having more providers that can speak multiple languages, go into homes and help families. I'm with you, but we're trying. We're doing some things, but clearly it's not enough. Mm-hmm.
For the trainings that are available, California actually has an AT provider that gets grant funding. It's called Ability Tools, and you can Google that, and they have webinars, they have a loan and reuse program for assistive technology devices, and they'll definitely, I don't know if you're from Sacramento, but there's a couple of agencies here that actually do the training for AAC, but wherever you're from, Ability Tools would be able to give you the resources that you need to find out. And there's also a variety of independent living centers throughout California that know about assistive technology. And then in terms of the studies that you guys are doing, this is really wonderful. The whole personalized thought process around doing these studies and implementing these, the DTT and the Jasper is really amazing, because I think for parents that rigid ABA has been really hard. My son's 16 now, and we just stopped doing it because it was just so rigid. There was no personalized approach to it. So that was really exciting for me. Do you plan on doing any studies for children older than 8? And if so, if you're currently doing them, can you talk about them, or do you know any other folks that are doing that?
Well, there are a lot of folks around that are doing studies with adolescents for sure. I have a study that goes up to age 11. That's a medication trial along with Jasper AAC. It's ongoing. But I think I think what happens is that as kids get older and they're in school, you focus more, really the kind of work that we're doing is modular, right? So it's a module that can float into their intervention program, whatever that might be. So they tend to be more around social issues, but is your child minimally verbal? Oh, okay, because I think if you're minimally verbal, then you still can benefit from, maybe not Jasper with toys, but something around developing topics and using an AAC device. And I don't know, there are probably people here at the Mind that are doing some work related to this, but all over California there are researchers researching autism. And actually you have Lynn Abaduta right in front of you who does communication interventions. He's a good resource. See?
And we're doing that with adolescents. And so the idea is to really kind of give parents tools so that they can engage in interactions with their kids that are supportive of language. And what we found, and this is focused on children with Fragile X syndrome, which has a high comorbidity with autism, we have found that we can change vocabulary for kids that are already speaking, not so much impact on grammar, kind of on the complexity of their language, but we're still working on that as well.
I have a older son, and it's kind of piggybacking on her question. He was the first here in Sacramento for early intervention, and he was originally considered low functioning, mentally retarded. Now he's considered high functioning and hopefully going to college. But my question is, the programs really seem to drop when they get into older junior high, high school. He's having a really difficult time socially in high school, and it's keeping him back, even though academically he's college level. So that was basically my question. Do you guys have any programs that you know of that are junior high, high school?
Yeah, I think both of us do social skills, kind of social engagement interventions, and I go through elementary, I have middle, high a little bit, but you do more of that, Tris.
Yeah.
So there are programs, and especially for verbal kiddos, in trying to get them to more engaged in school and with their peers.
Yeah, so there's, there are social skills interventions that I think can be quite helpful, and they're really, kids get together once or twice a week and work on particular social skills, and I think that and there's work at UCLA on one of those programs that seems to have had a lot of success. I've also done work on really kind of helping kids learn some of the things they're going to need to do as they move toward adulthood, like if they're on medications or have other special health needs. We have to start thinking about how are they going to, if they're going off to college, how are they going to take over their health care? So those kinds of things. And again, we can have kids get together once a week or so, and our impression at this point is that we can be pretty successful in teaching them things that'll help them take those things over. But you're also right. I think people are making a general point here. There's been a lot more research on little kids than on older kids or adults, but it is a lifelong disorder, and we need, as researchers, to catch up to that. And we're getting there, but we're not there.
We're like turtles, not
Yeah.
hares, I guess. The airbnetwork.org, our website, has a bunch of studies that we've done. We've done several in-school settings, mostly with low-resourced kiddos, and a lot of those deal with social skills. So we have our intervention called Remaking Recess. It's very simple. The materials are downloadable. So if you go to the website, you'll get some free tools.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.